Good evening, friends. So today we are going to discuss few doubts which students usually have and they ask. So in this doubt clearing session, I will try to solve more and more controversial things and confusing things. One very important question which is asked and students are confused. Few doubts. Yes. Expression and consequent release of previously repressed emotion is called. Okay, when we do psychoanalysis, according to Sigmund Freud, yes, we can treat each and every psychiatric illness by psychoanalysis. Psychoanalysis, we do free association, means patient is asked to tell freely whatever is coming in his or her mind. That is called free association. A question is asked, what is free association, in which technique it is used? That is psychoanalysis. In free association, if a conflict is there, there is release of that conflict, those emotions, release or reliving of those emotions are called catharsis. Those are called catharsis. Catharsis is a broad term. It includes both painful emotion or normal emotions, any emotion which is released or expressed, that is catharsis. If we talk about painful emotions, so questions are asked, frequently asked question in which answer is usually abreaction, but recently they also mentioned option catharsis. So catharsis and abreactions are two words which are used interchangeably, but to be more precise, catharsis all emotions, abreaction painful emotions. Okay, now this recent update in your synopsis 12th edition, in context of a major loss, which of the following is symptom that distinguishes major depressive disorder from grief? In normal grief, what happens that if after the death of loved one, patient becomes sad, sadness of mood is there, decreased appetite, decreased sleep, means all symptoms of depression may be present. But how you will differentiate depression and normal grief? This is many times controversial, no clinical, no clear-cut guidelines, but with few points you can differentiate normal grief from depression. In depression, the mood is constantly sad, persistently sad, persistent dysphoria. Yes, persistent dysphoria. But in normal grief, the sadness comes in pangs. Pangs means waves, means the patient will remember the loved one. When he or she would remember the loved one, he would become sad. But after that, he would become normal. Means somebody comes to the person, family member comes, they crack a joke or tell something past event which is event related to happiness, then patient become little bit normal. So this is very important criteria. Yes, and I have taken these points from latest edition of synopsis 12th edition, in which they have clearly given signs that bereaved person has progressed to depressive disorder. So this is a potential topic, frequently asked topic, and sent update is there. So this may be a thank you, happy Holi to all of you, and definitely all festivals, whenever any festival comes, then I say yes, try to do your work, as at this time you are your work is study. So at this time all goddess travel together, means Saraswati, goddess Saraswati. Yes, who do believe in God? Yes, for those, yes, I believe in God. Ma Lakshmi, everybody is traveling together, yes, in this on this occasion, and anybody who is studying, that will be blessed both by knowledge, both by money. So I believe in such a way. So this is the belief system. Yes, psychiatry is nothing but a study of normal human behavior. We can improve our behavior, we can improve our thinking, and we can have more confidence. So may this festival bring you more and more color in your life. Definitely it would be, because we are here, we are devoting our time, yes, in study, and this is our primary goal or primary aim. So now we discuss that sign of bereaved person which has progressed to depression. Beliefs: grief person and their relative perceive bereavement as a normal reaction. Okay, sometimes patient himself believe that is normal, and so if patient, yes, who is in depression, yes, view themselves as sick, means patient would himself tell you that I am feeling sick, or may actually believe they are losing their minds. So this is subjective, not objective, so leave it. Emotional reactivity: yes, I told you emotional reactivity means persistent, and emotional reactivity, I told you, if somebody comes and tell some good things, the patient become little bit happy. Emotional reactivity if absent, then you will think of depression. Psychomotor activity: in depressed patient, there is, yes, there is drastic marked psychomotor retardation. So you will keep in mind and you will remember this table, and this will help you to solve clinical question. Guilt: although bereaved person often feel guilty about not having done certain things that they might save the life of the deceased loved one. Guilt of omission. Okay, they typically don't experience guilt of commission. What does it mean? Yes, omission and commission means I could not do something, that's why he died or she died. It's okay, but I have did this, I have done this. Okay, means done commission. Yeah, if commission, then guilt of commission, then depression. Delusion: delusion of worthlessness, sin, psychotic experience, general points towards mood disorder. So delusion, if delusion is there, so think of, yes, depression. Suicidal ideation, mummification, yes, wherever you feel that patient is going to commit suicide or suicide attempt is there. Yes, I usually teach in my class also that if suicide attempt is there, that is depression. Mummification: mummification is not that mean keeping the body embalming, that is keeping the items of the loved one. Yes, anniversary reaction. Okay, yes, so anniversary reaction, these are the points, okay, which will help you to remember and to understand. Okay, now one controversial question about this is: elderly housewife lost her husband who died suddenly of myocardial infarction. MI: after a week death, she heard his voice clearly talking to her as he would in routine manner from the next room. She went to check out but saw nothing. Okay, means it is a normal grief. In normal grief, occasional hallucination are common. What I said? In normal grief, occasional hallucinations are common. But if hallucinations are continuous, then you will think of psychosis. Okay? But so till now, if a patient comes to you, question is asked, till now you will say patient is having normal grief. But subsequently, she often heard his voice conversing with her, and she would also discuss her daily matter with him. Means daily matter discuss कर रही है, means continuous hallucinations are there. This provoked anxiety, sadness of mood. She was preoccupied by his thought, unable to sleep, decreased appetite, no interest. Means depressive symptoms are there. So patient is having depression and psychosis. So depressive symptoms are there, that is clomipramine plus haloperidol. This was controversial question. Yes, in this we will not think immediately ECT. Clomipramine plus haloperidol would be the best answer in this scenario. Yes, please do reply. Whosoever is listening this video, yes, please do reply what is the answer of this question. Yes, I want your correct answer. Please do attempt. As I told you that not only in psychiatry, in other subjects also, a little change, a single word can change the answer, and we are confused. So let me start discussing 40-year-old male. The age is itself indicating persistent delusional disorder, usually in middle age. Okay, now always doubt his neighbor and fights with him without any reason, means he is suspicious over neighbor. Yes, 1 year patient report occasional hallucination. Occasional hallucination that your wife is cheating on you. Yes, rest behavior is normal. This can be due to, yes. Now listen carefully. If I say this patient is having suspiciousness on neighbor, okay, and fight with him, means he is having delusion. But they have not specified which type of delusion. Actually, few questions are there in market and they usually confuse students, really confuse students. They are not complete themselves. But okay, we will explore the different aspects. Don't worry. Without any reason, he is having suspiciousness. So it is delusion. Report occasional hallucination. Hallucination are occasional. And hallucination content is wife is cheating on you. Means hallucination is there, delusion is there, duration more than 6 months, diagnosis is schizophrenia. Okay, now the only confusing point is occasional hallucination. Occasional hallucination, yes, but the content of hallucination is wife cheating, and content of delusion is doubt on neighbor that they might some do harm. They have not said that they are doubting neighbor that they are involved with my wife. Okay, with my wife. So we will say it is delusion related to neighbors and hallucination is related to wife. So better answer is schizophrenia in this. But in this question, so answer is B. Yes, Tushar. Yes, answer is B. Now, in the same question, if I change, yes, now please tell me what is the answer. Now please tell me what is the answer. A 40-year-old male has doubt his neighbor and fight with him without any reason. For 1 year, patient reports occasional hallucination. Rest behavior is normal. This is persistent delusional disorder. PDD is one delusion and occasional hallucination may be present, but content of hallucination should match with content of delusion. Means if they are fighting, he is fighting with neighbor, their content of hallucination should be fight of neighbor or suspiciousness over neighbor, but not on the wife. So understood, the answer is A. Very good, Sheikh Dharma. Yes, delusion of infidelity is not a diagnosis, but definitely in this hallucinations are coming, so that is not thought, that is perception. So this is not, can't be answer any way. Why paranoid personality disorder can't be answer? Yes, remember this thing. If I forget each and everything, I exclude the option. Why C option can't be? Personality is formed in adolescence. Personality is formed in adolescence, and yes, the duration of symptoms 1 year. Yes, duration of symptom is 1 year. Age is 40. So this can't be. Yes, 41 year. This can't be personality disorder. Usually patient of personality disorder will manifest in early stage. Okay dear? Yes. Now, are you getting these things? Yes, again this question asked by students. All of the following indicate good prognosis of schizophrenia except, yes, late onset. Late onset is a good prognostic factor. Good prognostic factor. Okay. Associated with depression. Yes, whenever schizophrenia is associated with mood disorder, that is good prognosis. Good prognosis. Developing country is poor prognosis. Mayank, answer is C. Yes, previously we used to say that developing positive symptoms are good prognosis. Positive symptoms are good prognosis. Developing country, this was previously we used to consider as good prognosis, but latest edition of synopsis, 12th edition, they have clearly written, yes, this is poor prognosis. Developed countries, good prognosis. Okay, so you remember this point. Previously, yes, all were good prognostic factor, but recent addition, synopsis, developed country have good prognosis, developing country have poor prognosis. Okay dear? Really, I found that good questions are being asked. Many students ask so many good questions, so I was really happy. And yes, this is very important recent update and frequently asked question. Please do reply if you can give. 25-year-old housewife came to psychiatry outpatient OPD complaining that her nose was longer than usual. She felt that her husband did not like her because of the deformity. Further, she complained that people made fun of her. It was not possible to convince her that there was no deformity. Her symptoms include, yes, please do reply. Yes, body dysmorphic disorder and body dysmorphic delusion. Yes, 3-4 questions are there. First of all, let me tell you that In body dysmorphic disorder, patient is occupied with his or her physical appearance, just like this lady says that my nose is of bigger size or is deformed, and these thoughts are coming and again and again, again and again. And now we found that body dysmorphic disorder has been classified under OCRD, obsessive compulsive and related disorder. Okay, obsessive compulsive and related disorder. In this question, listen carefully, this question has been asked multiple times, okay, and you will solve question wisely. So body, if a patient says that my nose is deformed, call to somebody or ask somebody, see a mirror, and ultimately everybody convince her that your nose is of normal size, she accept and she becomes normal. Again after some time these thoughts start coming again and again. So obsessive compulsive and related disorder, body dysmorphic disorder. Previously, what I said, previously we used to say, if this lady has firm belief, false belief, unshakable belief, and get operated for this deformity. Actually she is not having any deformity, but she is having false, firm and unshakable belief, so she would get operated for that. Then we say delusion, body dysmorphic delusion. Okay, very good. Body more. So in this question, yes, patient is not convinced, means false, firm, unshakable belief, then the answer would become body dysmorphic delusion. No, this was the old concept. Previously we used to say it body dysmorphic delusion because patient is not able to be convinced. Another name of body dysmorphic disorder delusion is body dysmorphic delusion. Another name is delusional dysmorphophobia. Both are same thing. What I said, B and C are same thing. B and C are same thing. And these two are part of monosymptomatic hypochondriacal psychosis. Confusing, I know. Let me tell you. A question was asked recently in 18 in AIMS. Yes, on monosymptomatic hypochondriacal psychosis. This is old name. What is monosymptomatic hypochondriacal psychosis? In which 3 disorder included. First is delusional dysmorphophobia, delusional dysmorphophobia. Second is delusional halitosis. And third is delusional parasitosis. Delusional parasitosis. Yes, delusional dysmorphophobia or body dysmorphic delusion are same. Delusional halitosis means that bad smell is coming from my mouth or from my body. Okay, now the new name according to ICD-11 is olfactory reference syndrome. Olfactory reference syndrome. Delusional dysmorphophobia, another name as I told you, body dysmorphic delusion. But now we say even if delusion is there, this terminology is not used. Better to say body dysmorphic disorder. Body dysmorphic disorder according to DSM-5. DSM-5 said even if the patient is having false, firm, unshakable belief, you will say the diagnosis is body dysmorphic disorder. Note this, body dysmorphic disorder delusional type. If you want to comment, yes, you can say body dysmorphic disorder delusional type. Why I am telling you so many details, so much of details? Why I am telling you? 2018 AIMS is not a means large gap. They asked this question in previous edition. Yes, you will find a detailed description of monosymptomatic hypochondrial psychosis. So this word is having historical importance. Even now they can ask this question. The 2018 they have asked. So you must know that in this same question, if one to choose, best answer is this. A is best answer. Sometimes you will find a question in which option A is not given in the question, then B, C, D. Out of B, C, D, B or C are having equal, they must not give both of them together. If they have given both of them together, no criteria how you will choose B or C. I think B and C are same. Okay, B, C. And if they have not given, just like 2018 question was asked, all these three are not given, then you can mark this D, monosymptomatic hypochondrial psychosis. Clear? So did you get this point? Please do reply. Yes, this is very important question. So again same doubt comes. That's why I have taken this doubt. Now this is a very commonly asked question. First thing is, let me tell you, recently asked topic also, differentiate between mania and hypomania. Yes, Mayank, thank you for your reply. Mania, hypomania. Recently they asked very difficult question. They wanted to differentiate you how we will differentiate mania from hypomania. So you will remember, most important criteria is socio-occupational dysfunction. Socio-occupational dysfunction mania में present होता है, means patient would not be able to function socially, occupationally. Hypomania में absent होता है. This is frequently asked. Second, yes, very good. Yes, very good. In any question, if you find the word hospitalization, very good. Your interaction is really making discussion fruitful. Hospitalization. If in this question anywhere you find the word hospitalization, without second thought you will think of mania. Psychotic symptom. Anywhere you find delusion or hallucination, without second thought mark the answer as mania. Okay, so these three I would give you the most important differentiating point. If these three are not given in the question description, then you will think of duration of or time duration, 7 days, 4 days. Okay, flight of idea, prolixity. Yes, I have given it flight of idea and prolixity to differentiate, but according to DSM-5 classification, what I said, according to DSM-5 classification, they have said that flight of idea may be present both in mania and hypomania, but flight of idea is common in mania, while in hypomania prolixity is common. It is written. So According to diagnostic criteria, you can't differentiate mania and hypomania by flight of idea, but in question purpose, you can differentiate. Okay, for question purpose, you can differentiate. Clear? Third thing, yes, if they gave pseudo hallucination, recently asked pseudo hallucination, present, absent. This is ICD 10. ICD, this is again not diagnostic criteria. Again I am saying this is not a diagnostic criteria, but it is said that pseudo hallucination are commonly associated with mania, and this time this question was asked, and they ask you to differentiate on the basis of this pseudo hallucination. If pseudo hallucinations are there or flight of idea there, then mania. And now make a mnemonic. Whenever you find manic episode, what I said, whenever you find, it is hanged I think, but no need to worry, it would be dissolved. Yes, if mania is there, without second thought, answer is BPAD1. What I said, mnemonic. If mania is there, without second thought, the answer is BPAD1. Okay, without second thought. If I ask you, now tell me, this is BPAD1 or BPAD2? Yes, mania is there, BPAD1. Suppose I say this is depression, hypomania. This is BPAD2. Means if mania is not there and hypomania is there, BPAD2. Now tell me the answer. Please do reply. What should be the answer of this question? Yes, what should be the answer of this question? Yes, in 19 or male, no psychiatric history, who has been experienced 4 days of irritable mood. Duration 4 days. Duration 4 days. Increased goal directed activities, brought to emergency department and subsequently hospitalized. Point it out. It is hospitalization is there. Okay. Yes, whenever hospitalization is there, without second thought, answer would become hospitalization is there, mania. And wherever mania is there, mania matlab BPAD1. Yes. Now, so this is clear to you. This is very frequently asked question in different ways. Very good, you all are correct. In which of the following disorder does the individual have the motivation to assume sick role in the absence of secondary gain? First of all, you will remember primary gain is unconscious pleasure. Yes, answer I have given, already given. Yes, this most probably hanged, so let me do it. I think it will take hardly 1 minute. So you will remember that okay, Okay, friends. So meanwhile, it is taking time. We will let me tell you that is factitious disorder or Munchausen syndrome. Factitious disorder or Munchausen syndrome. In Munchausen syndrome, means patient assumes sick role to get the attention of doctor. To get the attention of, yes, it is. Yes, you now it would be very easier for you to understand. Simple. These two, in this patient assumes sick role, means patient is producing symptoms deliberately. In these three, patient is not producing symptom deliberately. Patient is not producing it consciously. इन दिस पेशेंट जानबूझ के सिम्टम प्रेजेंट करता है. मेलिंगरिंग क्या है? मेलिंगरिंग इज नॉट ए साइकेट्रिक डिसऑर्डर. इन मेलिंगरिंग देयर इज सेकेंडरी गेन. मेलिंगरिंग में क्या होता है? सेकेंडरी गेन. Yes, you must have heard many time and seen many time in news that a politician was sent to jail. After 2 hours you will hear news that he got heart attack and now he is on medical bail. मतलब उसने sick role assume किया to get secondary gain. Secondary gain means bail. Factitious disorder, Munchausen syndrome, patient assumes sick role to get pleasure in the company of doctor. Not sister, okay? Not nurses. Doctors की company enjoy करता है. He want medical attention. Patient want medical attention. That's why he assumes sick role. He assumes sick role. Okay? Yes, factitious disorder, professional patient. Yes, let me tell you, Munchausen syndrome. Other name is Munchausen syndrome. So many stories on Wikipedia, Google करोगे तो so many stories would be there about Munchausen. But in very interesting story is that, very interesting story क्या है? There was a French soldier, Munchausen. Yes, I heard from my faculties also who taught me when I was preparing. Okay, तो ये story बड़ी अच्छी लगी मुझे. I enjoyed the story. तो what was the story? कि एक French soldier था. There was a French soldier who had this factitious disorder. वो क्या करता? पेट में दर्द हुआ, राइट इलियक फोसा. इफ यू फील, यस, इफ यू प्रेस यू विल फाइंड रिबाउंड टेंडरनेस. यानी कि जो मंचाउसन सिंड्रोम फैक्टिशियस डिसऑर्डर होते हैं, दे आर यूजुअली हैविंग सम मेडिकल बैकग्राउंड, सम मेडिकल नॉलेज होती है इन्हें. तो रिबाउंड टेंडरनेस, यू ऑपरेटेड. ही स्पेंड 3-4 days इन द कंपनी ऑफ डॉक्टर, नॉट नर्सिस. फिर बता दिया मैंने, डॉक्टर की कंपनी में उसे अच्छा लगता है. और रिसर्च भी हुई थी इसके बारे में कि वी फाउंड दैट दीज पेशेंट गेट ऑपरेटेड बिकॉज ऑफ द लविंग केयरिंग नेचर ऑफ डॉक्टर, बिकॉज द लविंग एंड केयरिंग नेचर ऑफ डॉक्टर्स. ओके, तो ही वॉज, जो मंचाउसन था, ही वॉज फ्रेंच सोल्जर, ही वॉज हैविंग दिस फैक्ट्री डिसऑर्डर, मल्टीपल operation, multiple scar mark on the abdomen. So his abdomen is sometimes referred as gridiron abdomen. What is gridiron abdomen? When everybody saw his abdomen, so much of scars, so many scars, they thought he earned these scars in war, and he was promoted to general. Later on, he was found to be having Munchausen syndrome and he was kicked out of the army. तो ऐसी स्टोरी है. Yes. Okay. So many stories are there, dear. So gridiron पे क्वेश्चन आता है. Marked यस मेडिकल नॉलेज पे क्वेश्चन आता है मंचाउसन सिंड्रोम. देयर इज ए क्वेश्चन वेरी फ्रीक्वेंटली आस्क्ड क्वेश्चन मंचाउसन सिंड्रोम बाय प्रोक्सी. यानी कि प्रोक्सी हम जैसे दूसरे की प्रोक्सी लगाते हैं. पेशेंट मैनी टाइम्स पेशेंट मतलब द पर्सन इज कंसर्न अबाउट द लव्ड वन. मदर यूजुअली होती है क्वेश्चन में, मदर इज कंसर्न अबाउट द लव्ड वन. सपोज मदर केम विद हर चाइल्ड एंड यू आस्क हर फॉर मेजरिंग द टेम्परेचर. शी डिप्ड द थर्मामीटर इन हॉट टी एंड शोड यू. तो जो हॉट टी में डुबाया तुम्हें दिखाया फीवर हो गया. मीन्स मंचाउसन सिंड्रोम बाय प्रोक्सी. ओके, you ask patient, yes, you ask mother to give urine sample of the patient. She pricked her finger, dropped one drop of blood in the urine sample. तो ये क्या है? मंचाउसन सिंड्रोम बाय प्रोक्सी. तो ये तुम्हारे डेलिबरेटली वो सिक रोल एज्यूम कर रहा है. इन दीज थ्री patient is not doing deliberately. Patient have somatic symptom, multiple somatic symptom, yes, and patient is concerned with symptom. Illness anxiety disorder, patient is concerned with lethal disease, myocardial infarction. Conversion disorder, just like patient have stressor, in after stressor somebody is scolding and patient goes into pseudo seizures. That is conversion disorder. You must be having little bit idea. In this primary gain conversion disorder, both primary and secondary gain, both are there. So this is factitious disorder in the absence of secondary gain, only and only primary gain in factitious disorder. Clear? Yes, this question has been controversial many times. Yes, students are asking the same question and making mistake. Yes, you must know that yes, every time debate starts ki what should be the treatment, what should we do, you must know that depression may be unipolar depression. Suppose this is depression, I say this is a unipolar depression, and in unipolar depression we give antidepressant, okay. Unipolar depression we give antidepressants, you all know, and antidepressants are chosen on the basis of, yes, मैंने अभी डिस्कस भी किया था पिछली क्लास में, बेस chosen on the basis of side effect profile, chosen on partially on. Now partially, वाई हम क्यों कहते हैं पार्शली चूजन ऑन साइड इफेक्ट प्रोफाइल? क्योंकि कई मैनी टाइम्स मैनी टाइम्स वी चूज antidepressant according to their quality also. Just like a patient of depression comes to me having sleep disturbance, I don't want to give benzodiazepine, I can give mirtazapine. Mirtazapine is having sedation, so it is not a side effect, it's a advantage. So why I would say it is a side effect? So mirtazapine we are using that. So this is simple concept by which you can remember. Otherwise now synopsis latest edition they have given antidepressant chosen partially on the basis of side effect profile. Okay, ये मैं डिस्कस कर चुका हूँ पहले भी YouTube डिस्कशन में, कोई बात नहीं. Now yes, unipolar bipolar depression. What is bipolar depression? Suppose a patient is having mania, now comes to depression means past history of mania or hypomania, then it is a bipolar depression. If a patient comes in bipolar depression, never give antidepressant alone. मैं बड़ा सिंपल सा एग्जांपल देता हूँ हमेशा क्लास में कि तुम यू आर पोस्टेड इन इंटर्नशिप एंड यू आर लुकिंग एट योर प्रेस्क्रिप्शन ऑफ योर कंसल्टेंट टेक हिस्ट्री एंड से डिक्रीज एपेटाइट, डिक्रीज स्लीप, लो मूड, सैडनेस ऑफ मूड, डिक्रीज इंटरेस्ट, डायग्नोस्टिक क्राइटेरिया ऑफ डिप्रेशन इज फुलफिल्ड, दे राइट एंटी डिप्रेसेंट and past history definitely they take, you ignore that. Every time you they write antidepressant. One day consultant went to attend the emergency, and you were sitting on the chair and you are taking feel of consultant. Sometimes we take, I have also done that, and yes, we took feeling of consultant. Patient came to me, patient came at this point, I took history, diagnostic criteria of depression is fulfilled. I did not take the past history. In past he was having mania, and I started antidepressant because I have seen so many times my consultant starting antidepressant in case of depression, but these were unipolar depression. There were no past history of mania, but in this patient you ignored past history and you started antidepressant. Patient, yes, very good, patient will go to mania. Now this patient came after 3-4 days, 5 days, 6 days. Now patient came to having excessive expenditure. Yes, property बेच दी अपनी, yes, ट्रक बेच दिया, ट्रैक्टर बेच दिया, घर बेच दिया, yes, and distributing notes, okay, rupees. तो manic patient, okay. तो now he is switched into mania, इसे कहते हैं switch. So we say in bipolar depression, never give antidepressant alone. Never give antidepressant alone. You can give olanzapine plus fluoxetine or lithium. You can give. Both are questions. But ये तो हमें देनी चाहिए थी. We should have given these drugs, but you have not given. You have given antidepressant. Patient is switched to mania. When patient has switched to mania, now patient is in mania. You will not give antidepressant more. Immediately stop antidepressant. Why? Because antidepressant was the causative agent. एंटीडिप्रेसेंट वाज द कॉजेटिव एजेंट. जब भी कोई डिसऑर्डर होता है जो कॉजेटिव एजेंट होता है उसको पहले रोकना होता है. तो वी विल स्टॉप द कॉजेटिव एजेंट, दैट इज एंटीडिप्रेसेंट. देन वी विल थिंक ऑफ मैनिया बाय ट्रीटिंग बाय मैनिया विद मूड स्टेबलाइजर. ओके, I would stop imipramine. In this depression, patient was being treated by imipramine. After 2 weeks treatment, the patient developed over talkativeness, euphoria, over familiarity, insomnia. मतलब वो क्या कर गया है? Switch into mania. What's the best next step management of this patient? Answer is stop imipramine and start valproate. Yes, I have taken this table from latest edition of Synopsis. Yes, I will share this on Telegram channel, our Telegram channel. Okay, these PDF. In Synopsis they have given these features of depressive episode that are more predictive of bipolar disorder. Okay, recent edition of Synopsis they have given more and more table, and they have compared DSM-5 with ICD-10. You will be surprised that when ICD-11 has come, they are giving ICD-10. Yes, they have given ICD-10. Okay, and means you will not immediately switch to ICD-11 immediately. You will not mug up each and everything of ICD-11. Think like that. I don't say that you should not, but think like that. And yes, so questions are being asked in this way, that they are asking the difference between ICD-10 and ICD-11, what changes are there. Okay, so keeping in the mind whatever changes are there, they are potential question. Yes, so if depression occur in early onset or psychotic depression before 25 year of age, postpartum depression, especially one with psychotic features, so chances are there this may go into bipolar disorder. Recurrent depression more than 5 episode, rapid onset and offset of depression episode of short duration. Yes, if marked psychomotor retardation, atypical features, seasonality, family history of bipolar disorder. So I know that this is very exhausting table, difficult to remember, but we have little bit idea. If early onset multiple episode has occurred, so you will think of that chances are there, family history of PPAD is there, so chances there this depression may go into bipolar. Okay, yes. Now next question, DSM-5 diagnosis included in obsessive compulsive related disorder. Yes, OCRD. Yes, yesterday also I discussed this. Thanks dear. Yes, we will take a few sessions, don't worry. We will try to cover as much as possible. Okay dear. Yes, this is one more important point I would like to, a controversial point, that is in mania, best mood stabilizer is, best drug is, if acute mania, question is asked, acute mania, what is the treatment, best treatment? Okay, and according to synopsis, they have given a table in which they have given that first line drug of mania, and lithium is the first word they have given. So we started saying that lithium is the best mood stabilizer, we should choose lithium. But after this synopsis, Maudsley latest edition came, NICE guideline came after this synopsis, and in Maudsley latest guideline, NICE guideline clearly says that in Cochrane review, antipsychotic were found to be having better result than lithium. So antipsychotic. Thanks dear, thanks. Yes, antipsychotic. So now if you go with synopsis, answer should be lithium. According to NICE guideline, answer should be antipsychotic. Better, according to me, go with antipsychotic. Why? Because this is written that in meta-analysis, yes, you will appreciate what is the significance of meta-analysis and Cochrane review when you will do PG. Okay, that it is clearly written that antipsychotics are better than lithium, and they have given the guideline. Even previously I used to say antipsychotic is better. Yes, even now I say antipsychotic is better choice if they give only one to choose. Okay, lithium, yes, in pharma it is written that lithium is the best mood stabilizer. Definitely, if we say, lithium is fulfilling the criteria of best mood stabilizer. What is best mood stabilizer? So many properties, means which act both upside and downside, means which will act on mania and also in depression. So best mood stabilizer, yes, this is lithium. But in clinical practice, acute mania, best drug is, first drug to use, antipsychotic. Clear? Now DSM-5, which of the following diagnosis is now included as an obsessive compulsive and related disorder? Yes, this question has been recently asked, and in this again I would like to mention trichotillomania, pulling of hair again and again. This is obsessive compulsive. OCD, you know, repeated hand washing. So OCRD, you will remember, wherever repeated words is there, repeated, yes, you will say that OCRD. So trichotillomania, again and again pulling hair. Previously this was impulse control disorder. Yes, impulse control disorder. Yes, lithium also take time. Yes, few days to put their action. Okay, so many times we use in combination. Yes, definitely lithium takes time. And a question is asked, lithium, after how many days we check the lithium level? 5 days. After how many hours of last dose? 12 hours question. So previously impulse control disorder, now it is obsessive compulsive related disorder. Yes, very good. Gambling disorder, previously it was impulse control disorder, but now it is addiction. It is addiction. Okay. Yes, this question has been asked by many students. They are confused about post-schizophrenic depression. Yes, after schizophrenia, depression is quite common, and in this depression, suicide rate is also high. So what is post-schizophrenic depression? Suppose there is a patient, suppose a patient comes to me, he is having schizophrenia. I made diagnosis of schizophrenia. I started treatment. When I started treatment, patient started recovering and most of the symptoms are recovered. Only one symptom, means few symptoms are left. Okay. Now, within 1 year, patient started having sadness of mood, decreased appetite, decreased sleep, means depressive symptom, which fulfill the criteria of depression. Depressive symptom which fulfill the criteria of depression. Very good, answer is C. Yes. So if a patient of schizophrenia is there and in this patient depressive symptoms appear, then you can make diagnosis of post-schizophrenic depression, but it has few criterias. One criteria, at this time depression criteria should be fulfilled, means you can make the diagnosis of depression. Let me explore with the question. A 36-year-old male had his most recent episode of schizophrenia relapse in 6 months ago. Yani 6 months back he was having schizophrenia. Means schizophrenic episode must be present within 1 year, but in this question 6 months, so it is less than 1 year, so this criteria is fulfilled. He responded well to antipsychotic, but still hear occasional voice, means some symptoms are still present, but now he has lost sleep, lost appetite and weight, and complain of low energy, pervasive anhedonia, low mood, means depression criteria fulfilled. So this is post-schizophrenic depression. Okay friends, so we close the discussion. Now the message, we can conduct more doubt solving session. You can ask any doubt, yes, during the discussion also. Yes, no doubt during the discussion, it's okay, but whatever doubts I have gathered from my students, yes, which were asked recently, I have included those doubts. Other than that, if you have doubt in my next session, yes, we can plan before the exam. If you have doubt, if I accumulate these doubts, I will do that. Okay, we as a DBMCI family always there for you to help, and definitely on this Holi, yes, the festival of color, yes, it will fill our life with more and more color. Yes, it will give us more strength, more calmness and more entertainment. One message I want to convey on this before concluding. Yes, play Holi tomorrow, but try to avoid hard colors and excessive water, because you are going to appear in exam. Even 1 day does matter. So don't yes, sometimes we are emotional, we are so tired studying so hard, and sometimes we think, okay, let me play, है ना, हट जाता हूँ पाछे ने नाचन दे जी भर के ने, है ना, ये गाना गा के, और you start dancing and taking bhang and all. No, till exam, no bhang, no addiction, only and only devotion, enjoy in study. तो 1 या 2 घंटे yes, spend with your family, spend your time with family, your loved one, your girlfriend, boyfriend, maybe also loved one, okay, it depends on you, yes, and rest of time try to invest your time, okay, this will give you immense pleasure कि yes, हमने आज का टाइम भी इन्वेस्ट कर दिया. तो बेस्ट ऑफ लक, remain positive, and wish you a very happy Holi. Yes, over.